and welcome to our conference entitled Minnesota's Alcohol Use, State of the State, Webinar 2. My name is Brandon, and I'll be your operator for today. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session, during which you can dial *1 if you have a question. I will now turn the call over to Lisa Gall. Lisa, you may begin.
Good afternoon at the top of the noon hour here, and thank you for joining us today for our presentation on Minnesota's alcohol use, State of the State. This is our second of 3 webinar series. Today we'll be talking about screening and brief intervention to promote healthy lifestyles. The next slide. There are, for the purposes of continuing education, I need to read this. Because the educational credits are being offered for this presentation, we need to tell you that the speakers and planners have no conflicts of interest, no commercial support has been received for this webinar. For CE credits or a certificate of attendance, you must attend the entire session and complete an online evaluation. We encourage everyone to complete the evaluation to provide feedback on the session. Credits approved for today's webinar are CME for physicians, CME for nurses, and social work credits from the National Association of Social Workers. I have the pleasure of introducing today's presenter, Cindy Swan-Henderlite, who will be doing the second part of the webinar, and I myself will be doing the initial part of the webinar. And I'm Lisa Gall. I'm a nurse practitioner by background. I am a clinical program manager at Stratis Health. I've worked in family practice and ER, VA, bunch of other public health, and the last 7 years I've been working in quality and technology at Stratis Health with the Quality Improvement Organization in Minnesota. This is part of a series with our QIN, Quality Innovation Network, a 3-part state organization called Lake Superior QIN with Wisconsin and Michigan. And then I will hand this over to Cindy to introduce herself.
Hello, my name is Cindy Henderlite, and I work at the Department of Human Services. I'm a licensed alcohol and drug counselor. I've worked in the treatment and policy area of DHS since 2001. I fairly recently should mention that from 2001 until just this last year, that area was the Alcohol and Drug Abuse Division, and now we have been integrated with our mental health and children's mental health area, so now we are Behavioral Health Division of the Department of Human Services. And I'm happy to be here today. Thanks, Lisa.
All right. Thank you, Cindy. So our objectives today are to go over alcohol screening and brief intervention as part of routine care in practice. How to identify current and desired workflows and practice tools, choosing valid screening tools, using quality improvement principles for your screening to sustain your screening efforts. And you'll hear about Minnesota substance use disorder reform and how to mobilize community resources like the Minnesota Fast Tracker, and Cindy will be giving a demo of that. So one of the first steps into implementing an alcohol screening in your practice is to just lay the groundwork, make a really good plan. And how to lay the groundwork really is in the presentation of how you present alcohol screening to your patients and your clients. It's really more of an important medical service than checking up on someone. So we really need to make sure, though, that as you implement the screening tools, that you have the leaders' commitment. The biggest successes in implementation of alcohol screening has been because leadership is not only supported, but have actively promoted the implementation of the tool and given the resources for the people in the organization to work together. You do need to establish a planning team, quality improvement team. Most practices have that already, but the planning team should really involve clinicians and support staff who are really at the side of the patient and they also need to be instructed in how to use these tools in practice and how to effectively administer them. And then lastly, understanding and clarifying the roles of everyone's roles. If you want to move forward. So this is a really big piece of setting up roles and responsibilities, and it increases accountability and decreases gaps in care that could really undermine the efforts that you put forth unless you have clear roles. You just don't want to have someone dropping the ball in between when you've implemented such an important screening. The first session that was done a couple of weeks ago, we talked about motivational interviewing skills, and it introduced motivational interviewing techniques. And one of the decisions that your team will want to make is who should be trained in motivational interviewing skills. And part of the decision is finding out who's interacting with the patients and to what level. So for sure, the clinicians administering the screening and brief intervention will need to know how to utilize motivational interviewing skills, and even sometimes your front office and staff, support staff who are, if they're going to be handing the screening tools to the patients. You might need to give them some scripting and rephrasing to kind of abolish some of the old terms that we're using that are stuck with stigmatism, like the alcoholic, that kind of terminology. And so we want to, really get to using alcohol screening as a normal part of practice. So how to get the screening and brief interventions the next step, if you want to move forward, please, is after your planning and assigning roles and laying the groundwork is to choose and implement a screening and tool and brief intervention. So what do you do to choose a validated screening tool? How do you choose a validated screening tool? What's available? Obviously there are alcohol use screening tools and substance use screening tools, and there are multiple EHRs that have their own embedded questions in their frameworks. Many of them in the social history. And of course, what about a single screening? Do you need to do alcohol screening tool, substance use screening tool, and is there a single screening tool? And, we'll talk a little bit about that as well. So we do want to remind you that whatever tool you use, you really need to teach your clinicians how to administer and to interpret. This is a screening tool, not a diagnostic tool. I mean, it is still a clinical decision when you have someone who screens positive to do some further intervention. And so the SBIRT is screening, brief intervention, referral, and treatment. This webinar will cover just the screening and brief intervention. The referral and treatment will come a little bit at the end of this webinar, but also into the webinar in 2 weeks. What is the date of that webinar?
The 29th.
So May 29th. And they'll talk more about the referral treatment and medication-assisted treatment in that webinar. Next slide. So this is just the example of the audit, alcohol use disorder identification test interview. So the audit and audit tools were developed based on a standard drink as being 10 grams of alcohol by the World Health Organization. However, 2 of the researchers that were part of that development learned that in the United States, a standard drink is 14 grams of alcohol, which results in about a 20% false positive screening. So the researchers spent a number of years developing a tool that would reflect the norms for the United States. So these are very good questions developed by WHO that detects alcohol problems in the last year. It can be used in primary care, administered by health professionals or paraprofessionals. And generally the audit takes less than 5 minutes to complete, and the audit C takes less than 2, and we'll talk about the audit C in next slide. So this is an example of the audit C. So this is really I don't know if it's hard to see on our screen or
I don't know, but maybe you should read the question.
Yeah, I'm thinking, so there are 3 questions. The Audit C and Audit tools were developed by the World Health Organization. The Audit C is only a 3-question screening that can help identify people who may need further screening. So the 3 questions are, how often do you have a drink containing alcohol? And the answers are never, monthly or less, 2 to 4 times a month, 2 to 3 times a week, or 4 or more times per week. The questions in the Audit C are based on that 10 grams of alcohol per drink. The second question is, how many drinks containing alcohol do you have on a typical day of drinking? 1 or 2, 3 or 4, 5 or 6, 7 to 9, or 10 or more. And the third question, how often do you have 5 or more drinks on one occasion? Never, less than monthly, monthly, weekly, daily, or almost daily. And so for the scoring, you add items, scores, and a positive screening is 4 for men or 3 for women or adults over the age of 65. And I'll have you back up just for that last screening. You know, some of the questions in this screening tool also are, I'm just going to read quickly. I'm not going to read the responses, but so you know the content of this is the audit. How often do you have a drink containing alcohol? How many drinks containing alcohol do you have on a typical day when you are drinking? How often do you have 6 or more drinks on one occasion? How often during the last year have you found that you were not able to stop drinking once you had started? How often during the last year have you failed to do what was normally expected from you because of drinking? How often during the last year have you needed a first drink in the morning to get yourself going after a heavy drinking session? How often during the last year have you had a finding of guilt or feeling of guilt or remorse after drinking? How often during the last year have you been unable to remember what happened the night before because you had been drinking? And have you or someone else ever been injured as a result of your drinking? Has a relative or friend or a doctor or another health worker been concerned about your drinking or suggested you cut down? So those are the questions on there that you can't see on the screen. That can't very much. Sorry about the writing. 2 forward, please. So alternatively, for those who are not implementing a full question screening of the Audit C or even of the Audit or the Audit C, a single question screening and scoring can be used using a validated screening question. How many times in the past year have you had X or more drinks in a day? X is 5 for men, 4 for women, or adults over 65. And the scoring is patients who report having exceeded the number of drinks 1 or more times within the past year are considered positive screen. And that's when you would administer the full Audit US screen. Let's talk about the Audit US screen. So the audit screen that we just showed you a few slides ago was developed by the World Health Organization, and what has been redeveloped in the U.S. was something to more model what the habits of U.S. Citizens are. So we are generally drinking 14 ounces of alcohol rather than 10 in a typical drink.
14 grams.
14 grams. Sorry. Ounces, grams, 14 grams of alcohol versus 10. So our drink sizes are larger. So what they did is they modified the answers to this question to reflect more of the typical drink size and contents in the U.S.
And this is Candy Hansen.
I've invited Candy. Candy Hansen is one of the program managers here as well, and she's going to participate and chime in when needed.
So I'm a nurse by background as well, and I work with Lisa on the Behavioral Health Initiative here at Stratis Health. And what those researchers found was that while the audit feed had produced up to a 20% false positive with the questions that were asked in the Audit C, in the U.S. audit, it produced false negatives so that it wasn't picking up people who perhaps needed additional assessments. because of the amount of alcohol in a standard drink.
Thank you, Candy. Next slide. So the audit U.S. scoring is modified, as we stated, for the U.S. standard drink. Scores between 0 to 7 or 6 or 7 suggest abstinence or drinking below low-risk guidelines. And at that point, you only are encouraged to educate on risky drinking limits, so, as part of your education on healthy living. Scores between 7, 8 to 15 suggest that the person is drinking above recommended guidelines, and you, at that point, have a brief intervention. And again, it's just education, and saying, and maybe even suggesting, or asking the patient what they're willing to do to become a healthier, having a healthier lifestyle, just like you would in diet or other exercise things. So scores between 16 to 24 suggest that drinking above the guidelines and that they are experiencing alcohol-related harm, potentially. And so the suggestion there is to do brief intervention and follow-up. If they're scoring a little higher, a little more at risk, you really want to have a follow-up with this patient and to discuss their, alcohol patterns and drinking and health in another visit. A score of 25 or more suggests alcohol dependence symptoms, suggests, not states. I mean, this is all clinical judgment, and these are guides only and screenings only. But at this point, referring to a specialized alcohol treatment may be required in cooperation with your, patient on what they're willing to do or bargaining with your patient. So the next slide is the Audit 1 to 3. It's the U.S. version of Audit C with scoring changes. Again, we did go through the Audit C there, and in 2014, just to help this process, the CDC published an implementation guidebook for primary care for alcohol screening, and they really endorsed the Audit 1 to 3 and the U.S. audit for alcohol screening in the U.S. While the questions are similar, the answers and scoring are different in the Audit 1 to 3 and the U.S. audit. If you indicate, for example, that you drank 4 times a week for question 1, you would score positive under the Audit C. But that doesn't align with the NIAAA,
National Institute of Alcoholism and Alcohol Abuse. NIAAA.
So that said, there's an issue about whether in the U.S. we should be drinking 14 grams of alcohol as a standard drink. Well, we can't stop that, I guess, but that's an ethical question clinics have to wrestle with, and our own individuals. These are the first 3 questions from the U.S. audit. Question number 3 is the standalone single screening question that is validated in the CDC guidelines. And we talked about that. The U.S. audit 1 to 3 scoring modified for U.S. standard drinks. This is the scoring score is on a scale of 0 to 18. Each question has 7 choices from 0 to 6 and a total of 8. A score of total of 8 or more for men is considered positive, or 7 or more for women or adults 65 and older is considered positive. Screenings that requires a little more investigation. Next slide, please. Again, this is kind of a fuzzy slide, and I apologize for that. A lot of information. If you do want to zoom in on your own PowerPoint, you might be able to see this a little better, but basically tells you the U.S. audit. It's a quick reference guide. There's a card that shows you how to score the U.S. audit, and it's just a reference for you, and it's available in some of the websites that we will be giving to you at the end of this session. Anything to add in here?
No, it's actually a double-sided pocket guide, if you will. And so the next slide shows the shows the back.
Okay, yes. Yeah. So this is the front and the scoring, and then the next page is the quick reference guide on the front, where you can actually show your patients what is a standard drink, so that if they're drinking a tap at a brewery, their beer may be a bit stronger than your typical beer in a bottle. So then we can't talk about screening tests without talking about other substance use disorders, because they can and frequently do go hand in hand, where people have multiple drug or chemical use disorders. So the drug abuse screening test is a validated tool with 28 questions. It screens for illicit drugs, non-prescription, and medications. There are two versions, which are self-report and clinician-administered. And the DAST-10 is 10 questions. It's more brief, condensed from the 28-item DAST as well. And these are, I won't go into those into detail other than showing that they're available as screening tools as well if you work in a high-risk population. So screening and brief intervention in practice. So we talked first about getting the plan, laying your plan, and then choosing a tool, showing you the tools, and now how do you get this to go in your practice? So how do you implement screening? How do you do the brief intervention and implement individualized care? And that individualized care we'll talk a little more in detail about in our next webinar, and that's the referring for further evaluation or outpatient treatment. So for today, we'll talk more about the screening brief intervention. The third, one thing you do want to make sure is that you're implementing this. If you are implementing this, you want to make sure you're tracking the data, and reporting it and sharing it, and just really helping others and yourselves to improve on your quality of screening practices, and keep track of how many people you're screening, how many positives, if there are any issues, what are those issues. Get your patients involved with that as well. And then implementing your screening brief intervention for alcohol and other drug use in medical settings. So this was a really good slide. I don't know if you can zoom in there, but it's the Expert Change Guide 1.0 was developed by the National Council for Behavioral Health with funding from SAMHSA. And they basically really laid out what are the clinical changes that are needed to do an effective alcohol and drug use screening. So first, you really need to screen all adults at least annually to get a normal part of your care. Secondly, elicit symptoms. It's not just screening. You've got to talk to your patient. Are they showing symptoms of alcohol use, dependence, or risky behaviors? And then a third, brief counseling. A few sentences to say, these are the guidelines. Were you aware? And how can you improve? And then manage use disorders, with the clinical decision supports and shared decision-making with your patients. And then do some follow-up and monitoring. It doesn't have to be the clinician always calling back, but maybe if someone is at risk, that you have a plan in place that a care manager or somebody calls them back. So the organizational changes on the right are, we talked about leaders, supporting the improvements using quality improvement processes, primary care workforce trained in alcohol or other drug-related care. It's not something we've received in our initial training as clinicians that, we're learning. And so we're relying on the alcohol and substance use disorder specialists to help us to learn how to care for patients in the primary care setting. And then finally, how to bill and identify other financial resources for alcohol or other drug-related care. So how do you get this to move in your practice to do screening and brief interventions? You really want to decide who delivers them, what are the elements they'll use, train the staff on interventions for their roles. We talked a little bit about all of this, so I'm not going to belabor it. But you do want to really be clear on who's doing what, who's doing the brief intervention, who's doing motivational interviewing. I mean, really, you don't want your front staff giving brief interventions. You want them to administer and hand out things and not really getting involved into that level. But you do want them to be aware of the language they should be using when they're talking with patients when they enter the clinic and how to make it a normal part of care. So do some goal setting. with your patients, instead of saying, can you abstain, it's really a hard goal for some people to do that, and maybe an unrealistic ask. So maybe you would ask them, how do they think they might be able to cut down, or how much do they think they could cut down? And refine your plan after a pilot test. Use your plan, do, study, act cycle for your quality improvement, and then you resolve your issues before you fully implement after your pilot test. And then manage rollout for successful implementation. We talked about the PDSA methods. Just a quick note here, publicize your efforts so others can learn from your experience. And here's an example of the brief screening, and I would like to just show you this really educational exchange between a provider and a patient on doing brief intervention in practice and making it a normal part of care.
Hi, I'm Ed Boudreau, and I'm here with Jen Hurley. We'd like to welcome you to the enhanced bite-sized learning on how to introduce alcohol screening to a patient in primary care. I'll first review 3 key performance elements, then we'll provide a few role plays of common situations. 3 key elements to keep in mind when introducing alcohol screening that can help put patients at ease and foster strong patient engagement are: number 1, introduce. Introduce the screening and describe why it is important. Don't just drop the screening in the clinical evaluation with no explanation. Number 2, explain. Explain that this is done with all patients to help reduce stigma and to provide the context of universality. And number 3, ask. Ask permission to continue with the questions after you introduce the topic of screening. Okay, we'll start with our first scenario. In this scenario, the patient is being seen in primary care for an annual well visit. It's common to screen for health behaviors during these visits, but it's still a good idea to introduce the screening to the patient. I'm playing the role of the clinician, and Jen is playing the role of the patient. Okay, Jen, as part of well visits, usually ask patients questions about behaviors that can affect their health. We ask these questions of everyone, regardless of who they are or what medical problems they have. It's just part of the standard way we do things so we don't miss anything important. Do you mind if I ask you some questions?
Sure, I don't mind.
Okay, great. I'm going to ask you a few questions about your use of alcohol. And then the clinician would transition to asking his or her standard alcohol screening questions. We're not going to actually review the screening items in this presentation because it's something we plan to focus on in a dedicated exercise like this one at a later date. So in closing, let's highlight the key points that we saw during the scenario. The introduction destigmatizes the question by emphasizing that they're asked of everyone. It engenders patient engagement by explaining its purpose and by asking permission. If the patient happens to be reluctant, you can probe further reasons for reluctance. And if the clinician begins with another health behavior, like tobacco, for example, the assurance of the universality of the screening can still be used prior to introducing whatever health behavior is being screened. And then alcohol screening can just be fit into wherever it's most appropriate. Okay, let's move into another common scenario, which is when the clinician performs the alcohol screening as part of an unscheduled visit. In this scenario, we're pretending the patient is presented for persistent nausea and vomiting, and the clinician has completed his or her exam and has all the information he or she needs to diagnose and treat the nausea and vomiting. He is then going to do some basic health screening. I'm playing the role of the clinician, and Jen is playing the role of the patient. Okay, thank you for explaining to me what brought you in. I think I have all the information I need. But before I talk to you about what I think should be done, I have a few more questions to ask. As part of visits like this one, we often ask general screening questions of everyone, regardless of who they are or why they're here. It's just a part of the standard way we do things, so we don't miss anything important. Do you mind if I ask you some questions?
Okay, sure. Whatever you want.
Okay, great. I'm going to ask you a few questions about your use of alcohol. And then here the clinician would launch into the screening question that is used at his or her practice. So in closing, let's highlight the key points that we saw during the scenario. The introduction destigmatizes the question by emphasizing that they're asked of everyone. It engenders patient engagement by explaining its purpose and by asking permission. If the patient happens to be reluctant, you can probe for the reasons of reluctance. And if the clinician begins with another health behavior, like tobacco, for example, the assurance of the universality of the screening can still be used prior to introducing whatever health behavior is being screened, and then alcohol screening can just be fit into wherever it's most appropriate. Finally,
and I think we'll stop there just to make sure that we have time. There are, on the Lake Superior Quality Innovation Network website, there are a series of bite-sized learnings that are there to help go through screening scenarios, such as if you've identified someone at high risk, how can you talk to them about that, and what might your next steps be? So now I think we'll go ahead and turn it over to Cindy.
Thank you. My part of the presentation today addresses the individuals that you work with who disorder that are set out in the DSM-5.
I'm sorry. I didn't realize somehow you got muted again. Do you want to start again?
Oh, sure.
Sorry about that. I don't know how that happened.
Okay, sorry if I'm repeating it all, but my part of the presentation today will address the individuals that you may be working with who are in the mild, moderate, or severe levels of substance use disorder that's set out in the DSM-5. And when I refer to substance use disorder, I'm referring generally to alcohol use disorder, opioid use disorder, or any kind of addictive substance. 10% of the population falls into these categories, and state data show that only 1% of this population currently receive treatment for substance use disorder. You can go to the next one if you want. Okay. In the 2017 legislation here in Minnesota approved substance use disorder reform, and specifically it's outlined in Minnesota Statute 254B.15 if for some reason you wanted to have all the specific details. But generally, once completed, and we're still in the process of implementation, so some of these parts of substance use reform have been implemented and some are still within our systems work to have implemented. But essentially, reform will change substance use disorder treatment in Minnesota from an acute care model to a chronic disease model of care, similar to diabetes or hypertension or asthma, mental illness, or any other illness that requires behavioral changes for optimal recovery. And since substance use disorder are chronic conditions, recovery is supported best when both physical and behavioral aspects of the disease are addressed. The goals of reform include improve and promote strategies to identify individuals with substance use disorders, to ensure timely access to substance use disorder treatment, to expand aftercare and recovery support services. And some of the specific ways we're doing that is by 2 new services that have been approved by the Centers for Medicaid and Medicare, and those are peer support services and treatment coordination, both or either pre or post treatment of substance use disorder. We are coordinating and consolidating funding streams with local, state, federal funds to maximize efficiency. And we are increasing the use of quality and outcome measures to inform benefit design and payment models. Importantly, I think to this audience, we are coordinating treatment of substance use disorder. Our goal is to do this better with primary care, with long-term care, and with mental health delivery systems when appropriate. Some of the things, you can go on to the next slide. I guess I will just mention in passing that I'm sure many of you are familiar, as Lisa mentioned, that sometimes specific training on identifying substance use disorder or how to address, or if you're aware that a patient has a substance use disorder, what do you do with this patient? And there has been this kind of a black hole, and I think our field has been a part of that, and it's been siloed over here. And fortunately now, we are trying to blend, both primary care's focus is trying to blend this, as they did in much with depression work, And now our area is wanting to connect more with primary care. With the substance use disorder to connect with primary care. And I encourage people, if you do have substance use disorder treatment programs, either residential or outpatient in your community, that you familiarize yourself with them, perhaps visit them, tour them, allow people to come to your clinic, talk about their program, because so often it is a place that people are not familiar with. And oftentimes patients, when they did a lot of work about this in Wisconsin, they found that patients had the attitude of, I don't want to go to one of those places with those people, not realizing the people in those places are just like themselves or just like other folks in the clinic that you work with. One of the things that's changed with substance use disorder reform is if the patient that you're working with has insurance, you could look at helping your patient contact the member services number to ask if substance use disorder or treatment services are covered by their plan and which providers are in their network to go and have a substance use disorder assessment, either a Rule 25 assessment or a comprehensive assessment. And what has changed is that that service could come to the clinic. If the patient doesn't want to go to a program to have that appointment, a clinician from the treatment program could come to your site. It used to be that providers sometimes would do this gratis in a hospital or in a primary care if they were contacted by the medical staff, but the program couldn't get paid for that employee coming off site and doing an assessment at a clinic or doing an assessment at a hospital. Now it has changed that that program can bill for that service. It's also in the works, and this is the part that isn't fully implemented yet, that a licensed alcohol and drug counselor wasn't able to be an individual and bill an individual practitioner that bills the Consolidated Treatment Fund. And now that is something that a qualified professional that's worked as an alcohol and drug counselor for at least 3 years or has it within their scope of practice and has some specifics related to working with the population can provide these services at a primary care clinic, for example. They could come and do a comprehensive assessment or a Rule 25 assessment. They could even come and do some beginning outpatient one-to-one individual sessions and just do some kind of hand-holding or informational education about what treatment is, if it's something the patient is willing to look into. The other thing that, I think you can go to the next slide, I think I talked about this here, is telemedicine is fairly new in substance use disorder. I believe it was in 2017 that this was finalized, and so now assessments could be provided in person or via telemedicine, and obviously you have to be authorized to have that set up, and that is done through DHS, and you may be familiar with this process already just because you have been able to do this in other areas of medicine, but it is new with substance use disorder. And the other thing to mention, you can go to the next slide, just kind of ties in, I guess, to both, is if the patient is prescribed a medication to treat substance use disorder, the evidence-based practice is to pair that medication with behavioral treatment because that aids in adherence to the medication and engagement and support in the stages of change and motivational support to maintain or sustain long-term recovery. Another piece of substance use reform is something with withdrawal management. So it goes beyond detox. So often there was an expectation that someone would go to a detox setting for 3 days, which obviously is an acute service, and then be expected to have made major changes. That isn't, as you can imagine, that isn't treatment. It's just detox. And withdrawal management is a process that will involve 2 levels of withdrawal management have been approved for residential withdrawal management, and some will be provided perhaps in some of the county detox settings that choose to get this new license for withdrawal management, which has an increase in medical services. So for the American Society of Addiction Medicine, ASAM, criteria 3.2 and 3.7 are the 2 new services that are approved by CMS in Minnesota. The implementation, we hope to be completed by July of this year. So right now, it isn't something that's being billed for, but it will be something, and this is, like I said, a residential part of withdrawal management. So instead of the detox, which was more of a social type of service, keeping the person safe, but not really doing a diagnostic, not having a counselor there to start working with the patient as far as engagement, and hopefully then moving toward a full treatment, whether it be an outpatient or residential, just depending on the severity of what the assessment indicates. I think next, that's all I will cover as far as reform, and then I can go into showing you folks a live demonstration of the Fast Tracker tool. And the Fast Tracker tool is fairly new. Some of you may be familiar with it because it started in 2017. And I will just quickly mention that you can go to the link that we have provided to the website, or you can just Google Fast Tracker with 2 T's, and it will get you to this site. And I keep it in my favorites so I can quickly search on this online tool. So it's a tool that you, your patients, their family members, county assessors, care managers, and coordinators can go to find access to where there are openings for substance use disorder treatment in Minnesota, also for detox. And this is a site that is a voluntary site for folks to be on. There's no mandate at this time that all programs have to be on it or that all programs have to update it daily. But we have had very good results with people wanting to be on the site, and generally people having really good adherence to updating it on a daily or fairly frequent basis. Between January of 2018 and October of 2018, our data shows that it assisted over 5,000 searchers in finding sites for where there was availability, or also what types of programs are in their community, or which would be the most appropriate for one of your patients to consider. And there is going to be a handout that you have access to also that you can print off, because when I do these live demos, I know that it's difficult to remember all the points that I've gone to. And so I think the handout will help you in not only familiarizing yourself with the substance use disorder resources on this site, but also the mental health side of Fast Tracker, which I am not going to review today because we're focused on the substance use disorder. So I'm just going to get over so I can do the live demo and show you a little bit how this site works. So if you click on the box, substance use disorder, sometimes it takes a couple minutes or seconds, seem like minutes, and it'll bring you to this page. And you can search here, and then sometimes it doesn't show well on this screen, but there's also some tabs up above. There's one here that says Find Treatment. There's one that is kind of hidden behind the gambling. It says STR opioid grantees, one that has a helpful info tab, and one that is if you're an administrator. So these are where the programs, the substance use disorder treatment programs, update their information. So you can either go to Find Treatment or to search here and click there. And what comes up, as you can see, there's a search box. And so if you're looking, for example, for one of your adult patients that you think needs to consider going and having an assessment or contacting a program, maybe you're going to contact the program and see if they can come and do an assessment at your site. And one of the things you can also put in is your city name. So I'm going to put in Brainerd and see. And see what comes up for non-residential programs in the Brainerd area. And so 2 come up that have registered, and one is a Minnesota Adult and Teen Challenge, and the other is this program, Valhalla, is actually an opioid treatment program, so they provide methadone at that site. If you go on to treatment openings, it tells you what services they have. So they do adult residential, adult non-residential, they do assessments. And a lot of these terms are going to be repetitive. Chemical dependency treatment is the same as treatment, it's the same as alcohol treatment, but we have a variety of words used just depending on what the searcher might choose for how they're going to search the tool. Then this takes you directly to their site. So if you wanted to contact them about having somebody come and do an assessment at your clinic, that's something that they could do. I'm going to go back to this site, and then this for the OTP, the opioid treatment program, which are the only programs that can provide methadone. This site in Brainerd tells you what they provide there. When they list methadone, they also, I know, provide buprenorphine there, so I assume that's why they have medication-assisted treatment. They also have behavioral supports there, so that's why they list other types of treatment there. You notice that only 2 programs came up in the Brainerd area that were, when I Googled when I selected non-residential. I want to stress the part that this is a voluntary site. There's approximately 390 programs listed here, and that includes licensed treatment programs, licensed detox programs in Minnesota, border state programs in Fargo, Wisconsin, and South Dakota that work with the Consolidated Treatment Funds with public pay clients in Minnesota. One thing I should mention, I'm just going to back up for a minute. When I was talking about assessments, if someone that you're seeing is on medical assistance and needs to get an assessment and they don't have an MCO plan yet, if they have a network that they are connected with through an HMO, then you would contact them about where they can get their assessment done or which program could come to your site and do the assessment. But let's say there's somebody who recently lost their job and they don't have insurance and they're very likely going to be MA eligible. And then the county is who to be contacted to do the assessment. So the county of residence for the patient that you're working with can do the Rule 25 assessment, or they can let you or the patient know where in the county's network the person could go, or that program could have someone come to your clinic to do the assessment. Some of the other things that are on the site, we want people to know how to get to all the licensed programs in the state, and not only the ones that are listed on this site. So this is the Department of Human Services licensing site, and as you can see, there are 432 licensed treatment programs in Minnesota, and that includes outpatient and inpatient, and the opioid treatment programs, the OTPs. If you had a specific search you wanted to do, you could put the name of a program if you knew a name of a program in your community, and then you would go to substance use disorder treatment, and then click on that, and then a search, and it would come up. I also want to show you, if you had a patient that you were concerned about needing detox, they had perhaps decided to stop drinking on their own, and they were in their 4th day without alcohol and not in good shape. And, if the ER wasn't able to work with them, this licensing site shows all the detox listed in the state. There's 16 active licenses. And one of the reasons for our withdrawal management work here in Minnesota is that two reasons. One is because a lot of the social detoxes don't have the medical service in their county at the site to handle a lot of what people's needs are when they're coming into detox, especially if it's related to drugs other than alcohol. And also because of the availability. For our whole state, there's only 16 licenses. And if more treatment programs have withdrawal management services, especially in the residential programs, there's going to be more access available for detox and withdrawal management services. I'm going to go back to going through, for example, if you had a patient that was on that the physician decided, and the patient together decided they wanted to be on buprenorphine. But they also needed to find a program that was going to offer behavioral support. These programs work with buprenorphine, and they work with providing behavioral supports that people need to continue with their medication, to continue with behavior changes needed to maintain recovery, and sometimes that is maintaining total abstinence, sometimes it's some harm reduction towards total abstinence, depending on what the patient is willing to do and what's recommended by the medical and behavioral staff together. So there are some other resources on this site just to let you know about. And as you can see at the very top of the page, there's a quick link to a live chat for people who are dealing with gambling addiction, pathological gambling. There's also some helpful information on this tab because we know that sometimes when people are looking for themselves or for family members, or it could be a place for folks on your team to get some information. If you hover over some of these terminologies, we have definitions of what is substance use disorder, what is opioid use disorder, what is treatment.
Where was that tab again, Cindy?
That tab's at the top out of the page, and it says helpful info.
Okay.
Yeah, so it's above. It's right here.
Oh, I see. Okay.
And then it defines what office-based opioid treatment is. So prescriber that has a waiver and it can prescribe buprenorphine, and that they do that right in their office, and someone doesn't have to go to a methadone clinic for buprenorphine. Co-occurring, then these are direct links to sites that tell you more. This is Lisa before mentioned NIAAA, which is a part of NIH, and it talks, if someone is wanting to know more about what is treatment and what types of treatment are available, it's just a good resource for folks who aren't in this world and dealing with these kinds of terminologies all the time. And I think are we getting towards my end of my time, or is there more time?
I want to just take can we just take 1 minute to see if there's anything in the chat, if there are any questions in the chat quick, as well as would you please open it up to see if anyone has any questions, and if we don't have any more questions, we'll keep going for a few more minutes. So,
That sounds good.
For those of you on the phone, if you have a question, please press *1 on your telephone keypad. If you'd like to be removed from the queue, please press the # sign or the # key. There may be a delay before the first question is announced. If you're on a speakerphone, please pick up your handset first before dialing. Once again, if you have a question on the phone, please press *1. Okay, we have no questions on the phone at this time.
okay, sounds good. So go ahead, Cindy, and we've got a few more minutes here.
All right, on this helpful info page, there, as I mentioned, you can click on this link here, find buprenorphine prescribers. So if you work in a clinic, there doesn't happen to be someone who's a waivered physician, you could go to this site and...
There isn't a waivered physician in Minnesota?
These are all the waivered physicians in Minnesota.
Oh, I see. Okay.
I think there's 7 pages.
Oh, sure. Oh, there's quite a few.
There's quite a few. But the thing about waivered physicians is they have a limit on the number of patients that they can work with. And so sometimes they may be a waivered physician that may not have any openings to work with anybody else. So I think the first year they can have 30, and the second year they can have 100 or 250. It's been increased to. And APRNs can also be waivered. And there is no mandate that they have to be listed on this site.
Sure.
So when individuals call me and at the state and sometimes ask about where they can find a waivered physician, I say ask in your clinic where you go now for your health care, because there may be one there in that clinic but doesn't choose to list. And that still is, I must say, related to stigma. Because people don't want their whole clinic with those people. well, those people are us, right?
Exactly.
And so there's, slowly but surely that is changing. But it is a reality still. Some other things on here that I think are important to talk about is if I scroll down, there's national resources that you can find here. One of the things that a lot of people have in their practice now, I'm not sure why that is. That's an oops. But through the Steve Rumler Hope Foundation, through a lot of the work that we have done at the state also with the Minnesota Department of Human Services, or with the Department of Health, folks who are prescribed opiates for pain are often recommended to have a naloxone kit also. And so this shows folks where they can get that. There are several Minnesota recovery community organizations now, and those are the organizations that have peers. So individuals that are in recovery themselves, that are specially trained, that know how to navigate systems, because sometimes patients need other, whether it's job, whether it's other living situations. But now there are 6, so I can see that we need to update this site to have the other ones. But recovery happening is down in the Rochester area. Minnesota Recovery Connection is in the metropolitan area here. Minnesota Alternatives is in the northern suburbs of the metro, and Beyond Brink, I think, is also in the metro and specific to other population. I think it might be specific to, it's in Mankato. So, yeah, there's several of those in your communities, and then there's just some other public resources that you may not be familiar with.
All right. Well, we're up to the top of the hour. Thank you so much for demoing this. This was, wow, what a great resource. And so if we learn of someone that's a provider that's not connected with Fast Tracker, how do they get on this resource?
If there was a treatment program or a mental health clinic in their community that wasn't on here, they could just contact the Fast Tracker folks that's on the information that's on the Fast Tracker site, and they can get listed on there. And the mental health side usually has mental health clinics and then some individual practitioners. The substance use disorder side currently just has licensed programs or tribal programs, either licensed by DHS or by the border states. But soon, because this is so new, where there will be individual addiction counselors in private practice, they will be eventually listed on this site.
Great. Well, thanks again. We want to remind everybody that in 2 weeks we'll have our final of the 3 webinar series, where we will have Dr. Jane Peterson and Dr. Friends talking about what happens when a more intensive intervention is needed. And so you'll be receiving an evaluation when you pop out of this webinar. And we really encourage you to fill it out, because it really helps us know how to improve future webinars and so on. Oh, yes, the webinar, the 3rd webinar is on the 29th of May. So, you can get to it from our website, correct? And otherwise, please feel free to email either Lisa or Cindy if you have any follow-up questions from today. And thank you all for joining us.
Thanks, everyone, for joining us. Thanks, Cindy, for sharing your day with us.
Yeah, appreciate it. Thank you.
Thank you. Ladies and gentlemen, this concludes today's conference. Thank you for joining. You may now disconnect.